A very good morning, everyone. Refractive surgery is seeing a major paradigm shift. It's seeing a major paradigm shift, and we are evolving from LASIK to a lenticule-based platform. It is a flap-free version with a smaller incision size, more tectonic stability, lesser cutting of corneal nerves, lesser dry eye, and no risk of post-operative flap dislocation. But as we move on, every technology has its own set of complications. One of the complications unique to this platform is black islands. That is, the laser, the femto misfires and is not able to deliver energy. If it is outside the lenticular area like this, it does not really matter. If it is outside the pupil area and small area like this, maybe there is slight increased resistance. Larger area, still we are able to get away with this. If the width is less than 1 millimeter, generally we are able to get away with dissection, but rarely you might encounter something as bad as this, where entire upper half, the energy has not been delivered. Well, ideal case in this scenario is to abandon the surgery and take it up for a PRK or a femtolasic later. But what if the surgeon is biased and ends up starting the surgery? What if you are stranded in this? It's a difficult case. We are going to present one such case where we were struck up and we were able to finally complete the surgery. Well, just immediately after the firing on the PI patient interface, we could see this kind of deposits. Probably the reason. Energy and everything was fine. This is a short surgical video. The energy fires in two planes, anterior and posterior. Anterior plane, generally, despite the black island, you are able to still get through. Like here, there is increased resistance in the superior half. But with repeated efforts, the dissector is able to get through in the anterior plane in the entire area. The trouble starts when we go into the posterior area. We are still in the anterior plane, upper half, lot of resistance, inferior half, almost no resistance. It is done. Now we start the posterior half. Posterior half, we are not able to get through after a certain limit. After multiple attempts, the pointed edge tends to break through or leads to sort of a keyhole incision. The dissector just cuts through the lenticule from the posterior to the anterior half, and that's when we realize it cannot be done. Well, we could have still left the case, but the pressure on the surgeon, because of the commitment to the patient who had to get married after 5 days, made him proceed with the surgery further. So at this time, what were the options? You're not able to go posteriorly beyond this plane. And especially now that there has been a cut through in the lenticule, there is no way you can go further. So we decided now to go through the anterior plane further and start peeling off with the Sinski the lenticule. So this is through the anterior plane because inferiorly the energy had fired properly. With the Sinski, gradually we started peeling off the lenticule and the inferior half was completely dissected. But the superior half still, the energy had not been fired. So after multiple attempts, the entire inferior half, we were able to dissect the lenticule or peel it off. For superior half, because there was no energy fired at all, what option did we have? We could not have left the lenticule inside. So we decided to convert the keyhole incision into a sort of a semi-flap. This is still with Sinski peeling off the inferior half. Now with a forceps, we are pulling it. Till the line energy is fired, with the forceps, we are able to peel off the lenticule. You see, we are able to peel off the lenticule till here. But now this is the line where energy was not fired. And this is where the lenticule gets struck. So proximal 2 or 3 mm, the lenticule just could not be taken off. So just like relaxed smile, we just partially opened up the incision. It was the laser center, we did not have access to proper instrumentation. With whatever means we had, we sort of did a lamellar keratoplasty, imagine in a refractive surgery patient who was to get married 6 days later. With the crescent, we were able to get a smooth plane, take off the lenticule, smoothen the bed with a knife again, put the flap back, thinking, hoping and praying that the patient does not curse or does not convert into a medical legal liability. Luckily for us, everything went well. Even the island which was left over was removed and trimmed. Again, basically a lamellar keratoplasty in a patient of refractive surgery, which is the most dreaded nightmare for any surgeon. After putting it back, luckily the patient recovered 6 in 3 days, which is something no one expected. Even the post-operative topography showed uniform sagittal and instantaneous curvatures. Well, later in retrospect, when we go behind and we realize that while wiping the surface with the wet sponge, the mebum on the cornea was not properly wiped off. And just while firing, we can see the superior half, laser energy did not fire. This was the black island area. When the surgeon was cleaning the eyes, because of the bells, the eyeball rolled up, and that's when the entire corneal surface, see, this is the mebum deposited on the PI. This is the post-operative topography at 1 week. Patient did not follow up after that, but the topography of the left eye looks as good as the right uncomplicated eye. Just a quick recap of what exactly happened. Center surface. Was the right eye, this is the left eye. Now see, when the surgeon is trying to clean the eye, the bells has uprolled the eyeball and only the inferior half of the cornea is cleared of mebum. The superior half is projected in the upper lid and did not get cleaned. Probably the reason for this large area of black island. Thank you so much.
Sahil, that is a very bold step you took just 5 days before her marriage. You took this case.
So this was
That's too much of a boldness.
I was called as a rescue agent because the lenticle could not be removed. So my job was to remove the lenticle when it was struck up. So guy, 5 days later, imagine the stress on the primary surgeon and on me. This is something which, again, as I said, it is a disclaimer, should not have been done. We were lucky we could get away with a good result. Not every time we would get lucky like this.
Definitely.
So, means what about the haze? You could have used mitomycin C.
No, this is in the interface, not on the surface. Unlike PRK, where you expect haze, the healing was complete. It was epithelialized. No pain, no haze.
Epithelial ingrowth because you opened
no
it?
Ingrowth, no ingrowth.
How much
Again, we had a short follow-up. We had a follow-up only for 2 to 3 weeks.
Okay, 3 weeks only you have. Excellent.
Thank you so much.